Oh, I'm sorry. Is this? All right. Oh yeah, Becca, we talked. Yeah.
Thank you very much for having me.
Thanks for.
Yeah, absolutely. I don't want to.
Welcome everyone to New Hampshire, lovely Lebanon, New Hampshire, on this beautiful weather that we have today. And welcome those of you that came from Vermont, Massachusetts, Connecticut. Did anyone come from anywhere else? Rhode Island? Do we have some Rhode Island people in the room?
Maine.
Maine, we got Maine. Can't forget Maine. So welcome. Pennsylvania, wow. Did anyone come further than Pennsylvania? Florida, wow. Okay. Great. Well, welcome all of you. My name is Melissa Mio. I'm the president of New England Hymns, and we welcome you here to Lebanon. I just wanted to thank some of the folks that actually put this event together. It takes a village to put together an event like this for everyone, and I wanted to thank the head of our speaker committee and past president and my mentor, Mary Maloney. Without her, we'd be in a lot of trouble, so thank you, Mary. Mike Canarellis, who is also a chair of our speaker committee. And Mike, thank you for what you've done to pull together this event. And also of the fabulously talented Pat Ryu. Those of you who know her from the sponsors know her well, and she also helps with speakers. So thank you, Pat. I also want to thank Andy Deneen, who helped get some of the speakers here. So thank you, Andy. Amy Jennings, who helped coordinate this as well for all the sponsors. Katie Flynn, who helped with all the registration, and Pam Warhol. So thank you. We'll cover a few housekeeping items. If you could silence your phones now, that would be great. There's nothing worse than a speaker, knee-deep in a conversation and the phone goes off. But we all have to work. We understand. You have your day job. So if you have to step out, go right ahead. But if you could silence your phones, we'd greatly appreciate it. The restrooms are out the door past the registration to the left if you haven't found those already. And we will be having lunch in the dining area, which is in that main foyer when you came in. That's where we'll be having lunch. And then we'll have people come back in to see our sponsors at the end of the lunch period. So, sounds like we're in school, right? Lunch period. Back to high school. I also wanted to acknowledge our board members that we have here. Mary Maloney, past president of New England Hymns, Pat Ryu, Mike Canarellis, Matt Bornstein, our incoming president and friend, and Pam Warhol. So thank you all for the board members that are here this morning. Before we kick off our program, we can't do programs like this without the sponsorship that we have from all of our sponsors, and several of them are here today with tables, so it really does help make sure that we can afford events like this and keep the costs down. So I'd like to acknowledge and thank them, and if you get a chance to go by their tables today, just wanted to let you know that some of them will be raffling things off, and we'll do the raffle at the end of the day. So make sure you go by their table, give them your card, talk to them. They're not going to stalk you. They're nice people. They just want to support New England Hymns. So if you could do that, that would be great. We've got all scripts here. We have CloudWave, Jayco, Reporting MD, Add-on Data and Human Scale, Echo Store, OneView Healthcare, Sage Data Security, Wolf & Company, Lenovo Health, Dimension Data, and Queen Consulting Group. So thank you to our sponsors that are here today. And just to share, I wanted to share our mission with you. Our mission is to foster professional growth, relationships, knowledge, and collaboration among healthcare information management professionals in the New England region. So it's really great to see all of us here connecting. So make a chance today to kind of meet other people you don't know instead of hanging out with the people that you do. It might be nice to learn what other people are doing, what's going on in the world of healthcare IT. We're in a turbulent time right now, and it's interesting times. So you never know who you might connect with and who may be able to help you here. So with that, I'd like to welcome our first speaker. We're going to have some of our sponsors help with our speakers. So if Tony DeFrancesco could come up from Dimension Data, he's going to introduce our first speaker.
Good morning. Thank you, Melissa.
My name is Tony DeFrancesco, as Melissa mentioned, and I represent Dimension Data's healthcare practice. We're very happy to be a sponsor of the HIMSS New England chapter, and my colleague Kobe and I are standing there in the back. Love to talk to you about our offerings. Quite simply, we're a systems integrator. We're a fairly large organization. We're a big Cisco reseller, and we have technologies that span from contact center to telehealth to virtual patient observation, security, mobility. I won't give you the whole roster, but I'd love to have some time with you at some point during the day. So with no further ado, I'd like to welcome our first speaker, Mike Costa. Mike serves as Deputy Commissioner of the Department of Vermont Health Access, which administers Vermont's public health care system in this position. Michael leads the department's payment and delivery system reform efforts, rate setting, reimbursements, and fiscal and administrative operations. No further ado, I will bring up Michael. Thank you.
Good morning. Can everybody hear me? Yes. Great. Thank you for the warm introduction. I'm Deputy Commissioner of the Department of Vermont Health Access. That means I'm a Medicaid administrator, and I can assure you that when I was in right field in Little League, as other kids dreamt about the World Series in Fenway Park, I thought someday I'll be a Medicaid administrator. So dreams do come true. And I'm here at this great meeting, and I appreciate the opportunity to be here and talk to all of you who are great problem solvers. And I was just thinking a little bit about my own problem-solving abilities. Like a lot of high-level bureaucrats, I'm an attorney by training, and I couldn't really figure out how to turn the mic on. And I remember my father was a union gas fitter, and I have two brothers, and my brother Neil, he would say, "That's a great job fixing that, you're pretty handy." And my little brother Joseph, he would say, "That's a great job fixing that, you're pretty handy." And then he would look at me and say, "Listen to me very closely. It's going to be important that you read books." So, not particularly handy, but I'm glad that we figured out the technology challenges and we're ready to roll. We're here to talk a little bit about transition, transformation, and turbulence. And there are three words that I think aptly describe where we are, beyond the nice sense of alliteration. And so just to start out, you know, anytime I'm talking about healthcare or I'm at a conference about healthcare and healthcare reform, there are a lot of words circling through my head. So the word cloud really exists up there. It's talking about value, we're talking about alignment, we're talking about reform, we're talking about macro and other changes at the federal level. And so for me, prior to the transition to Governor Scott in Vermont in January, I worked for the previous governor. And I spent a lot of time as Deputy Director of Healthcare Reform thinking about the future of healthcare, both Vermont and nationally. And I was working on something I'm going to talk about today, which is the Vermont ACO all-payer model. And so, you know, it's just another way to try to align payers to simplify healthcare and to make healthcare more sustainable and more value-based. Another way to get at the AAA. But, you know, it's interesting, working for the previous governor, I remember distinctly right before we were about to sign the agreement with CMMI, you know, they asked, "What's your opinion?" And I said, "Well, you know, it's great that we're doing this. It's great that we're going to engage in provider-led reform. But the best piece of this, the best piece, Governor, is that it provides some certainty. We don't really have to wonder about what the big vision is. We just have to go and execute it." So I'll tell you that I said that to him on October 26th, about 2 weeks before the presidential election. So, which my word cloud went to this. Right? I was sitting there preaching to people that this will finally bring certainty to healthcare reform in Vermont, but there's been a lot of uncertainty since. Whatever you think of the national election, the sort of future of healthcare reform is maybe a little less clear today than it was a few months ago. And so it reminds me to be really humble about what you know and what you don't know. And you know, particularly in state government, I don't feel like we spend a lot of time talking about humility and integrity, and I think we should spend more time about it because there's only so much you can control, and you should be really honest about the questions you can ask and the questions you can answer and where we might get. And so I've been trying to approach my new job, particularly as a Medicaid administrator, with a good deal of humility about what I know and what I don't know about healthcare reform in the future. So let's talk about transitions a little more. So you show up and you're in a new job, And state government, and I'm sure the federal government's a little bit interested, where the entire senior management of the organization changes at noon on a day in January. And so, if you think about that in your own organizations, that'd probably be a pretty strange way to do business. And so I left the governor's office for one administration around 11 o'clock in the morning and went to a different building about 15 miles up the road and took on a totally new job an hour later. And so you get there and you start working with the people that are trying to bring your hopes and dreams to life with information technology. With our health services enterprise, you say, okay, what's the plan? And then they give you that slide. That's the plan. And so when you talk to the folks, and we have a great team, we have a hardworking team, you want to go back to basics and say to them, hey, let's talk a little bit about storytelling. As a leader, I can't support what I don't understand. When you give me this, I'm sure this makes sense. I don't really want to think of how much we probably paid for this slide, right? But I can't support this if I can't tell the story. So we really need to, be humble about what the story is. Try to get into a storytelling mode. We've got to a point where we're trying to think about the future of health IT in Vermont for us as a Medicaid agency and trying to get into analogies that decision makers can understand. Are we buying the car, or are we leasing the car? And you hate to oversimplify, but that's the starting point. And so it's a time in state government, a time in federal government where it's a good time to think, how do we tell our story? You rely upon subject matter experts like yourselves in making decisions and implementing the vision, but you have to start somewhere. And in the transition, I've become keenly aware of, you really are dependent on people's storytelling to make sure you understand what's going on. Because like a lot of senior leaders, you're in a really vulnerable situation. You're really relying upon what people tell you. And you've got to start with this basic thing before you can build up to our slide right there. The other thing in transition, like I said, it's a strange thing in state government and federal government where the entire sort of decision-making apparatus turns over every couple of years. And for us in Vermont, this is kind of a particularly difficult time because we have new governor, new Speaker of the House, new Senate President, new Lieutenant Governor. And so you're working on projects. If you think of your driver diagram, you've been driving in a certain direction for a long time, and then all of a sudden you have a whole new group of people, and you have to check your assumptions. And so we've been engaged in this real balancing act, and I'm certain they are at the federal level too, of what was the vision in December of 2016, what's the vision now, right? And the good part, if you look at it as an opportunity, because anytime I face adversity in life, I think if this were a blessing, what would it be? It's, right? Because the alternative is to just go in my car and drive away, right? And so I'm just trying to think, okay, this is a real opportunity to clarify our thinking. It's a real opportunity to fight for sort of what we really check our assumptions and fight for what we think the right vision is to serve our beneficiaries and to serve Vermonters. We really had to engage in a lot of that, particularly with both our health reform projects and with health IT, since we have totally new management. So that's the big picture. You've got this transition happening both at the state and federal level where you basically have to hit the pause button and you have to go. And I think we talk a lot in state government about lean manufacturing, which of course comes out of Toyota, and the sort of empowerment of allowing anybody to pull the cord and stop the line. And you hear that and you think that's great, but in a transition you see that actually happen. And it's a jarring thing and something that we have to negotiate together, and I'm sure you have to do in your enterprises as well. So with transitions, what I think is be humble, be prepared to tell your story, and be respectful of all ideas, both old and new. Because for me, when I talk to people who are going to be commissioners or cabinet secretaries in Vermont and other places, I tell them, look, about 90% of your success depends on your upper managers. The people who were there for the last administration, and they were there the administration before that, and they're going to be there after you go. And so if you come in and you're completely dismissive of their ideas, you're going to have a huge problem. At the same time, if they're closed-minded to your ideas, you're going to have a real problem. And so we spent a lot of time trying to think just simple charts. Hey, give me a stoplight chart. What's red, what's yellow, what's green? Hey, can you give me a chart of what the vision was in 2016 and what the vision is now? Because the first time we did that, we found that a lot of times it's exactly the same. Where people are talking about change, but they really haven't changed their vision at all. So we're trying to be respectful to old ideas and respectful to new ideas. So this is more the transformation part of it. So I said before, Vermont has been engaged in sort of at the forefront of healthcare reform for a long time. The previous governor went after single payer, that didn't work. And so came out of that I think Governor Shumlin asked a really interesting question. Instead of going home, he said, okay, what's the best thing we can do? We said, well, all of this really relies on cost containment, right? You really can't do much else in healthcare until you get sustainable costs. And so we immediately pivoted to a new project, which was what we call the all-payer model. And so our big goal, shouldn't be a surprise to anybody, is the triple aim. We want to improve patient care, improve population health, and reduce per capita cost growth. So we want to make healthcare more sustainable. So we set out to do that, and the big issue in that is basically, so go Medicare, so goes everything else. And so how do we get Medicare to pay in a different way? So we spent 2 years working on this, where we had a Vermont all-payer model agreement. So basically we reached a contract with the federal government where Medicare agrees to pay in a different way. They're willing to make capitated payments for a cohort of folks, make those payments prospectively, and give you some local control about how it's run in exchange for some guarantees. The other driver we're using is, hey, if you're Medicaid, you've got to stand up a program that can help meet those goals as well. We're going to talk about that for a minute. So, does everybody here know what an ACO is? Yeah. You know, I realized that, I just started adding this bullet when I go out and talk because I always assume people know what an ACO is and half the room doesn't. And now I'm in a room of people who probably definitely know what an ACO is. But just in case people don't know, ACO is just a group of providers that come together to take responsibility for the cost and health of a population up front. And so the ACO is really our vehicle. The reason why an ACO is special is because Medicare has programs that will pay in a different way, which is really important to us. So why are we using them? We want Medicare to be a partner in this reform with us. And we want to support provider-led transformation. And I can't overstate how important that is. We want to be able to partner with people in state government who do things that we can't do. And right now, we've been running fee-for-service for a long time. It doesn't work. We don't get the quality we want. We don't get financial results we want. And so our sort of latest bet is that providers and provider organizations will have a better success than government will in changing the way care is paid for and getting better results. And we have experience with ACO-based reform. So we had a shared savings program coming out of the Affordable Care Act, and we've kind of grown that up where it's only upside risk to now a point where it's willing to be larger and we can scale it up and take more financial risk. And why is it important? Because it's the only way to change our incentives. We really feel that there's something about empowering providers and changing the way we pay to a prospective capitated payment and putting providers some risk in their hands is the only way we're going to be able to go from fee-for-service and start chasing value instead of volume. So just to give you a visual of how this works for folks that don't know, you've got your 3 standard payers. You've got Medicare, Medicaid, commercial insurance, and that allows some complexity, but that's the basic ballgame. And instead of making fee-for-service payments, we set a capitated rate and pay that to the ACO. And then the ACO has a network of providers that it pays to. So right now, we have a lot of as a Medicaid administrator in charge of reimbursement. I pay fee-for-service to the entire Medicaid network. So now there are some people that have come together as part of an ACO where we've said, okay, we're willing to guarantee you this prospective payment for a number of people in your practice, and we're going to turn off fee-for-service. We still get shadow claims because we want to know what you're doing, right? Because quality and access become more important than ever if you're guaranteeing prospective payment up front. But we're going to turn off fee-for-service for those folks. So the 2 real keys are those prospective capitated payments tied to quality, and then the ACO can customize arrangements with the provider community. That's not something Medicaid can easily do or Medicare can easily do, right? I don't have the bandwidth to go out and negotiate with every single provider. Medicaid just kind of pays what it pays. We occasionally have one-off deals when we have to, but it's really labor intensive and it's not just something we're able to offer. And so we contract with an ACO. We say, look, we're going to give you X amount of dollars at the beginning of the year for a wide number of patients, about 30,000 patients so far, and you're responsible for those payments. And we're going to tie them to quality. We have a little quality withhold, which is going to get bigger over time. And you create arrangements that reflect wherever providers are in their readiness to get paid based on quality and take on risk. And then fee-for-service spending continues outside the ACO. So one of the challenges we really have is scale is really important. as I'm sure everybody knows here, because until I can fully get out of fee-for-service, I end up having to run 2 Medicaid programs at the same time. I end up having to run a capitated-based system, and I have to run the fee-for-service system. That costs me money with our claims payer, right? And it's really a burden on our staff. And so this is the general mechanics, or the fundamental mechanics of what we're trying to do with an ACO. And so we also made a bunch of promises. So we have this contract, with this all-payer model contract with CMMI, with the federal government, that runs from 2017 to 2022. And they said Medicare is willing to pay it a different way with these capitated payments. We're willing to let you customize that ACO program for the state of Vermont. But in exchange for Medicare behaving really differently, we're going to extract some promises from you. And they're pretty big. I know there's a lot of text here, but just really quickly, we want to get a truly statewide system. I think it's fair to say what the federal government's most interested in this deal with Vermont is being able to say, yeah, we tried an entire statewide system, which is a lot easier to do in Vermont than it would be in California, since we're a little smaller than some neighborhoods in New York or even pieces of Brooklyn, right? And so that's what we're doing. We're trying to better align per capita spending with economic growth. And this is kind of where the rubber meets the road. So the whole ball game to make healthcare more sustainable is to, squeeze down that difference between how fast healthcare grows and how fast everything else grows. So we've made some commitments that for services inside the model, which is basically all hospital and physician services, that on a per capita basis, we won't grow faster than 3.5% every year. We do not want to create, we promise to integrate across the care continuum. We have a lot of silos in state government, which we refer to as cylinders of excellence. And we don't want to create another one here with the ACO. And so the federal government said, look, you should start with Medicare Part A and B services and their equivalents in commercial and Medicaid, but over time you need to grow that. Most importantly, and for, Medicare Part A and B is almost everything in Medicare except for prescription drugs. In commercial, it's a whole bunch of what about 3/4 of what they pay for. It's really Medicaid, where it's only a minority of what we pay for, because we pay for a lot of human services. So basically, we just need to have a plan to integrate sort of the model from hospitals out into the community over time. And then quality, we've got a whole set of quality measures. Our provider community worked very hard with us on the quality measures. They said as long as they're not new, we're fine with whatever they are, right? And so we're trying to really focus on what would matter to Vermonters, which is access to primary care, looking to reduce chronic illnesses like COPD, hypertension, et cetera, and whatnot, and then offer an aligned next generation program. When you go back to this slide, basically the promise we made to the federal government is that Medicare, Medicaid, and commercial would offer the same program. So if you were a physician practice, if you got enough scale, it would be the same experience regardless of who the payer was. And that's a real challenge, and the Green Mountain Care Board, which is our healthcare regulator, has the responsibility and authority to make sure that happens. Just with all the text, which I'm sure you can read faster than I can talk, the things that keep me up at night, which is a polite way of saying scares the hell out of me, is that we need to have 70% of all Vermont insured residents, including 90% of Medicare folks by 2022. It's really, we challenged ourselves to say scale matters here. We cannot run 2 systems over the long term. So let's try to scale up as fast as we can. The financial targets, hey, there's financial, healthcare costs have been unsustainable for as long as there have been healthcare costs, right? And so it's been really intractable to get it to grow in alignment with the economy. And so we're really making a bet that if you empower providers and you make sure that the state is focusing on what it wants and providers are focusing on how it's done, and not really, conflicting those two things, that we'd be able to lower the cost of care. And so those are the 2 big things that really, for me, are a concern and a real challenge. As far as what's going on right now, the way we structured the agreement with the federal government was 2017 is labeled as program year 0. Only a room full of bureaucrats could come up with a program year 0. So we did. But that's really a getting ready year. The only piece of the system that got stood up in 2017 was the Medicaid program. The state of Vermont spent all of 2016 going through a procurement and a readiness process to launch Vermont's, the nation's first next generation ACO Medicaid program. The next generation ACO program is a product that CMMI offers to folks to innovate. That's really the chassis that we've used to build reform. And Medicaid stood up a program that runs for calendar year 2017 that has about 30,000 lives in it. And it's got all the building blocks that we think we need to succeed, even if the levers haven't been turned very far. We have a cohort of 30,000 lives that are being paid prospectively. So One Care Vermont, which is the ACO that we're under contract with, they know their 30,000 lives up front. They know exactly how they're getting paid. 0.5% of it is based on quality measures, and that's going to go up every year. There's a lot of reporting in place on that. And for them, 2/3 of it is in capitated payments. One of the interesting things we learned when we tried to stand this up on the ground was, and this makes a lot of sense, in the provider community, there's really a range of readiness for reform. So our hospitals, they're ready to go. They can take on risk. They can change their financial operations to take capitated payments instead of fee-for-service. You had a lot of primary care practices that want to get on the bus, but they're not ready to change their business model. So what happened, interestingly enough, is we said, look, we'll give you X dollars per life for 30,000 lives. 2/3 of that we pay in capitated payments, which are meant for the 4 big hospitals that are in there, including the University of Vermont, which is our big academic medical center. And then 1/3 of it's still in fee-for-service for people that are willing to be accountable but aren't ready to be paid in a different way. The big change in 2018 is that we're going to have a Medicare program and a commercial program stood up. So the Green Mountain Care Board is working with the ACOs, Blue Cross Blue Shield of Vermont, MVP of Vermont, and folks at CMS to make sure there's a Medicare and commercial program stood up in 2018. So at that point, you'd have aligned ACO programs across all 3 payers. And then, so the real goal in 2018 is just to take that next step and stand up across payers. 2019 is probably the first time where we can start to think about customization. So it goes from an off-the-shelf CMS ACO product to something that is a little more Vermont specific. So things we think about are attribution methodology. The whole thing relies on scale. We use CMS's attribution methodology. We might want to do something different in the future. But 2019 is really the first time that we can think about how to customize that relationship. And so, turbulence. So we've taken on a rather large challenge at a difficult time. I think even outside of the political piece, I don't know how many people are in the room, but I bet if I asked, hey, what's the future of informatics and healthcare, I might have some different opinions across the room. And everything I just described is going to be more dependent on technology and informatics every single day going forward. We're making a lot of promises that really rely on the work of people like you. And we're making a lot of promises that rely on providers solving problems that haven't been solved in a very long time. It's easy for me to say, as a deputy commissioner and a lawyer, hey, we've been trying it one way in healthcare for 50 years, let's try it a different way. But I'm not elected governor, right? And so our governor, Governor Scott, has been supportive of this. He's sort of relabeled it as a pilot project, because I think he's appropriately said to us, hey, you made a 6-year commitment with the previous governor, but we're going to monitor this 1 year at a time to really make sure that it's working for the people of Vermont, and you can actually achieve some of the promises that you've made to providers in Vermont and Vermonters and the federal government. I think that's a really appropriate approach, and I'm really grateful that we've gone forward at all, because it's a risk that the new administration didn't have to take. I could spend a lot of time talking about turbulence and trying to navigate unseen bumps in healthcare. But I think, instead of a laundry list of things that could go wrong, which are entirely outside of my control, amid this turbulence, I keep trying to focus on things that haven't changed. I keep looking at sort of the programs that are coming out from CMS and information that's coming out from providers, where our programs are at, for things that didn't change amidst all sort of the changeover over the last few months. And the focus is still on innovation. I have not really read anything about one of our big concerns in a new federal administration, bless you, a repeal of the ACA that involved a repeal for the Center for Medicaid and Medicare Innovation. We haven't seen that, right? We were worried about the impact on potential 1115 and 1332 waivers, so your Medicaid waivers and your ACA waivers. Information we're getting is that, hey, these tools are still there. The federal government is still interested in having a dialogue with the states. If anything, the federal government is interested in giving states more flexibility. We have politely made the point that, flexibility with less money isn't real valuable, right? I'm reminded of a great quote, which is, vision without resources is hallucination. And so, we've made that point to them, we've talked to them about that, but it's interesting to me that the fundamental building blocks of innovation haven't sort of been on the political table. And so I've really tried to focus our people on that and saying to folks, particularly in Vermont, which is typically a pretty blue state, where's the opportunity? Your job is to find the opportunity. Let's see what we can do with our federal partners. I think it's interesting, just to be candid, that in talking with CMS, we're getting kind of a twist. We're getting a lot of talk about flexibility at the very top. When we dig down and talk to the people who are sort of in the middle of the bureaucracy that we've been dealing with for a lot of years, there's been things have started to roll really slowly, right? And so we're kind of caught between a desire to give states more flexibility and an uncertain picture of how quickly or effectively the gears of the federal bureaucracy could implement or effectuate that innovation. And then I keep telling my people to stay on course. There's never a bad time for calm and assertive leadership, but this seems like an especially good time for calm and assertive leadership. I have a dry sense of humor, which now all of you have been subjected to. And occasionally I'll get at the whiteboard, I'll put up a little decision tree, and it'll say step 1, crisis, step 2, panic. And I'm like, has that ever served us well? No, so let's not start doing that now. And so getting people to really focus has been a challenge amidst all this change at the state and federal level and all the challenges that are embedded in healthcare reform right now, but it's really our job as leaders to keep our eye on the ball. For me, trying to get through this paralysis, I've worked for elected officials in 4 different states, and I spent a little time a long time ago, back when I had more hair as a speechwriter, and somewhere along the way I stole the line, pray but move your feet. Right? And so I've been telling folks here, when they get paralyzed, because for a lot of people this is their life's work, right? And they're now really uncertain about it. Just pray but move your feet. Keep on moving. Standing still is really not an option for us, given the commitments we've made to the federal government, and given the imperative of getting healthcare right, with higher quality care at a more sustainable cost. And then I have a theory, which could be totally wrong. I'm thinking back to my first slide, which is that moment where you give the governor your best advice, and 2 weeks later you realize it wasn't very good. When I was preaching the virtues of certainty amid healthcare reform right before the 2016 election. But one of my theories is that high quality healthcare at a more sustainable cost is a nonpartisan issue. I'm in charge of thinking about reimbursement for Medicaid for the state of Vermont. So I always look to CMS, I always look to Medicare. And for me, they've set up a real clear theory of reimbursement in the future. They got door number 1, which is fee for service, and they're gonna let you stay there, but through MACRA and the MIPS payment system, that door is gonna get awfully tight over time. And you might be a big winner, if you got high quality care at a low cost, or they might start taking money away from you over the next 7 or 8 years. Door number 2, if you get into an alternative payment model, which Vermont's all-payer model is one, they'll give you a 5% bump just for trying something new. And so when I think about the future of reimbursement in Vermont's Medicaid program, I start thinking about that same construct. Hey, I'll let you hang out in fee-for-service, but I don't know how much more I'm willing to invest in volume-driven care. I might be willing to pay more for alternative payment models, where people are really doing 2 big things. 1, measuring the heck out of quality, and 2, taking downside risk. So in the ACO model that we talked about for a minute here, the ACO is taking 3% upside downside risk, which is a really simple risk model. We had some really complicated ones before the Secretary of Human Services said, is the point to have a complicated risk model, or is the point to get the program off the ground? Which I thought was a really clarifying question. But for us in the state of Vermont, because we're not an MCO type state, for the first time ever, we have a little tiny insurance policy in our pocket. That the first 3% of losses in our Medicaid program are paid by the ACO in exchange for being paid for a different way. So for me, just like the feds, I believe in value-based purchasing. If I only have a limited number of dollars, I'm much more likely to invest in value-based purchasing than fee-for-service. And when I look at the vote for MACRA several years ago, which was one of the rare bipartisan votes in Congress, there were people from both sides of the aisle, I start to see this window of the next 6 or 7 years where we're going to do door number 1, fee-for-service, but it's getting tight, or door number 2, value-based purchasing, which we're willing to invest in. And then a moment 6 or 7 years from now, where depending on the results of that, and the results of state-based innovation, a moment of, hey, how much are we willing to really, did value-based purchasing work? And if it's worked or it's promising, how much are we willing to invest at all in continued fee-for-service? So I happen to think that that's a nonpartisan issue. But they don't pay me for political advice, they pay me to administer Medicaid. And so that's just my talk, and I'm happy to take some questions. I hope it made sense. I will tell you for the slides about the ACO program, that was a little bumpy for me. I dusted off the deck that I liked the most for the ACO presentation. It was 64 slides long. I said, we cannot do that in the morning. I cannot kick off this talk that way. And so I tried to get it to a more manageable number of slides, but you're pressing down on a lot of complexity at that point. So thank you. I'm happy to take some questions. Right there.
My question is about one of the ACO slides.
Yep.
The one that's the diagram, and sort of implicit in the program is all payer, being the commercial side. So related to the commercial side, could you just talk a little bit about, from a benefit plan perspective, right?
Mm-hmm.
Sort of health plans in your state, or are there insurance department rules around the benefit plans? Because certainly if you think of high deductibles or self-insured plans, people might opt not to get the care they need to provide the quality objectives that you have. So how are you approaching bringing commercial into the fold?
That's great. I was just having that conversation with the Healthcare Advocate's Office yesterday. Just a little level setting. So one of the things, we're in the previous administration in setting up this all-payer model agreement, we were the idea people. And you should always be nervous about idea people, right? And so we got this agreement with the federal government, and then through the Medicaid contracting process, we had to pivot from, hey, that looks like a neat slide, to how the heck does this work on the ground? Had to start to wrestle with issues that you described. And we've got stuck in a couple places. One, trying to let people know that this has nothing to do with your benefits, right? You get the same benefits now, and they still run between you and your insurer, not you and the ACO. You're not a member of the ACO. You're an attributed life, but you're not getting a card from them. That's been really confusing for people. But then you also have to deal with this sort of what happens with the change in the payment model. Because before, fee for service, hey, doctors and patients are kind of on the same page, right? Hey, if you think you need that extra test, I may not think it's a great idea, but I don't want to cause a conflict for you, and I get paid if I do that. So now, to the extent we've given you your capitated payment up front, there's an incentive for less care. And so we've talked a lot about that. The legislature in Vermont enacted Act 113 last year, which set up a pretty prescriptive regulatory regime for ACOs. And we're trying to get it, making sure we understand sort of what can be grieved and what can be appealed, like what's the process inside an ACO. But the real rub there is, how do you get to a doctor's intention, right? And so you really have to believe in two things. One, that doctors by and large do the right thing. And then two, you have to believe in your quality measures. You have to believe that you would see in the access measures that you've set up, and you've got over 30 quality measures in this, that you would start to notice it on a practice by practice level, or overall, if people were receiving a lot less care, and you'd start to ask them questions, why? And we also, one of the advantages of Vermont, because we're so small, is that, it makes you a more polite driver, because everybody knows everybody, right? And so the healthcare, there's no incentive whatsoever for me, who runs this program, to have a combative relationship with the Office of the Healthcare Advocate. So we're on the phone with them all the time saying, what are people saying? What are you seeing? Because we really, you're identifying a really soft spot in the model where it's hard for us to know how a doctor's decision-making is different. Now, we want their decision-making to be different in a way, because otherwise there's no point to doing this, right? But we're having a hard time measuring what's sort of good utilization, reduction in utilization, and what's inappropriate reduction in utilization. And going back to being humble, I'm just now starting to get the data about utilization in ACO. It'll probably take us about a year to be able to even start to tell a story about how utilization changes. My big worry, because I'm responsible along with the commissioner for being in charge of our $1 billion budget, is the ACO program has a suite of services that are in, that the ACO is financially accountable for, and then some services that are out, and pharmacies out. So we're very nervous about pushing down here and watching money come up in pharmacy, because like a lot of people, we do not have a good intervention to reduce pharmacy spend, and pharmacy spend is a huge challenge for us. So that's the first one we're looking at, because it hurts our bottom line. But you're getting at a much more nuanced and difficult but really important question. Go right ahead.
Yeah, Mike Gagnon, you know as well.
I do.
So if you're going to have one pipe to the ACO over time,
Yep.
and you're going to start shrinking the payments at the bottom, doesn't your organization have to eventually also shrink? I mean, they're going to become the risk-bearing entity, and you might still be the one who signs up Medicaid lives,
Yep.
but you're not going to manage the other side of the equation. It's going to be handed to the ACO.
Yep. Our expectation is that if this works, what the Department of Vermont Health Access does over time is really different. Right now, we administer something that looks an awful lot like a public MCO, right? We have our own utilization management team, we've got our own payment team, our own reimbursement team. To the extent we get scale, our workforce and our needs are going to change, and that's going to start to flow out into the private sector. The challenge is until you get scale, until you get proof of concept, we've got to do both.
Yeah.
And one of the most vexing questions in this whole thing, and a legislator asked it recently, and I was actually really grateful he did, was what's the right period of time for return on investment in this model? And we don't know. We have really struggled with that. We know 1 year is probably not enough, right? Particularly since, the answer is really, well, how long are you willing to give me, right? Is probably the true answer. But we're thinking really hard, what's the right amount? And the ACO, we kind of have a chicken and an egg problem with them because if you want scale, you need to make the fiscal model attractive enough. But I need to save money to perpetuate the fiscal model. And so for me, I've been trying to tilt the conversation to, let's stop thinking about cost savings, because anytime in healthcare someone brings savings to my office, I kind of throw something at them. And focus on sustainability. What's the right level of growth? In some years you're going to win, in some years you're going to lose, and you need to be okay with that. So we're trying to get to that point, but our business model really needs to change if this is going to work.
I have a follow-up too, and this is more for the technical and
Yep.
folks in the room. Aren't you also going, doesn't the ACO and then by the nature of this effectively everyone managing risk have to then have both clinical data and what we now call claims data,
Yep.
but the financial aspects of that data in the same kind of repository, or at least in a place where you can look at both of those sets and kind of see that what you're doing for quality over here impacts costs over here, and what you're doing for, if you do cost containment, it doesn't throw your quality measures off.
So yes, and I'll just provide a little more context on that. So one of my basic questions when we started this is, hey, what's the difference between the ACO and an MCO? Right? What's different than 20 years ago, the experience with MCO? And the two answers, high-level answers I get are basically, one, this should be, if it's done right, pretty much invisible to the patient, right? Because it's a provider community working with an ACO, not the patient being in the middle, which is a really precarious thing. And then the other answer is data. It's a more mature data environment now than it was when MCOs really took off, 20 years ago or a little longer. But that gets back to my point of, boy, I'm making a lot of promises based on how data works and how it can tie it in real time, how it can not only get tied in real time, but how it affects decision making. And we work with Vital, we work with Mike's organization, and I'm now more involved in sort of HIT as a thing for the state of Vermont. And I've been pushing our people really hard on two questions, which is, where do we want to go in the future? Because if we don't know where we want to go, any road's going to take us there. And also, as far as having a relationship with a vendor, if you don't know where you want to go, you are a terrible customer, right? And that's a real challenge for us because we have really limited resources. The other thing I think about is who's the appropriate person to own that relationship, because when I think about the ACO model in its most basic form, I think of Medicare and Medicaid and commercial thinking about what, and the ACO and provider community delivering on how. And so am I even the right person to pitch that health IT vision, or do I just leave that to the provider community? Now, the very specific problem we have in Vermont is that we've had a health information technology tax and fund for the last decade, and we leverage a lot of federal dollars that way, particularly with 90-10 match. And so for us, to the extent we no longer, if we're the state and we get out of the business of health IT in the provider community, we are reallocating a lot of fiscal burden onto the provider community because we're no longer drawing down federal funds. And so we put ourselves in a position where our reliance on federal funds kind of has to shape, like a lot of states, ends up shaping our policy, and I'm not yet sure whether it's in a good way because we've leveraged those funds and we get to pitch a uniform vision, or a bad way because state government's not traditionally the most innovative and most nimble player on the field. Other questions? Go right ahead.
I see that you're aiming to get 70+% of the population in the ACO as the MCO payer model.
Yep.
And from an organizational perspective, we're seeing that right now as a member of the ACO, it's more in the 30 to 40% of our population.
Yep.
So along with that, and you made a comment that you're having to figure out how to do this with a foot in both worlds.
Yep.
With your service and your ACO. What advice would you have to organizations that are you're on the payer side, we're seeing that same thing on the provider side. Do you have any advice for us on how to manage that transition between fee-for-service and paid payment?
Sure. I'd back up and then answer your question directly. I'd back up and say, a lot of times when the previous governor and the current Secretary of Human Services would ask me, hey, Michael, is this stuff going to work? My answer is always, I don't know. I have no idea, and I'm not an evangelist for it. I'm just looking at the way we've done things for a long time and said, I know that doesn't work. And I have a bunch of providers, and particularly our big academic medical center, which has got the biggest balance sheet, saying they're willing to give this a try. And I think it's worth giving it a try. And particularly since you can get Medicare, we've got consensus on the ground with a bunch of providers that they want to try this. We've got Medicare willing to pay in a different way. Now, thinking about your specific question, what I really like, and I'm having this dialogue with the ACO right now, is when I go to, say, legislators or policymakers to talk about this, they say, hey, we face a lot of investments that we can't make out of the community. We face a lot of community providers like social workers that we can't fund appropriately. We're sitting on a trove of data that suggests that those are the interventions we should be making, but mostly what we do is we pay for hospitals, right? That stinks, we don't want to do that. And so my gentle suggestion for the ACO would be, because to me, without the hospitals, ball game's over, because you need their skill, you need their buy-in, you need them to be an amplifier for reform. So my gentle suggestion would be, I don't know what the right time frame is, but get a box. If I had a whiteboard here, I'd have a big box that I'd label fee for service. And then I'd have 4 boxes next to it that say, okay, we pay for some things fee for service. It's naive to think all of that's going to go away. There's still going to be some fee for service going forward. Then there's going to be another box below it that says alternatives to fee for service. Like for right now, we're giving UVMMC, their academic medical center, a capitated monthly payment for its lives in our ACO program. And then a third box that says community payments, where maybe paying a nurse to go visit somebody in their house or a social worker keeps somebody out of the emergency department. And then a fourth box that says medium and long-term investments. Like the legislature would like to invest in ACEs mitigation and other things to help children because that will pay off later, but they just don't have the money. If you're the ACO, pitch me year by year what percentage is going to be liquidated from the fee-for-service box into these other boxes. Show me how all the money that's sort of accumulated in the hospital balance sheet gently over time gets out into the community, right? And if I could have anything, so I could go to policymakers and say, the point isn't to give hospitals more money. The point is to care for people. And if you give hospitals the right incentives and enough financial certainty that they're not going to go out of business, they are the best partners you'll ever have getting that money out in the community. But without somebody making that argument and showing them when it might happen, it's really hard, right? And for me, I can be very respectful of sort of probably the response I get from an ACO or a hospital, because they're like, boy, you want us to do that, but Medicaid's usually in the business of cutting our rates, right? So it is a really complicated dance to do with those. I hope that answered your question. What else? In the back.
Where are the issues with technology, if any, in order to go to a model like this?
Where are the other issues? That's a really good question. And I think, Mike's probably really interested in my answer. And it's really hard for me where I sit to answer that question directly. I sit here and I end up in rooms with, like, say, the quality people. And I say, can you get the data you need to do this on time? They're like, well, we think so. I'm like, what does we think so mean? Right? And so what I think we really need is really consistent claims data, right? We had to modify our own payment system to do that. We have a real challenge in the post-Gobet versus Liberty Mutual world, making sure we have a comprehensive view of claims data. And then, I guess it'd be, to me, a better question for the ACO, because I have to tell you the truth. I want to get out of the business of managing really complicated IT projects. I want to get in the business of saying to something like an ACO or someone like Vital or one of our vendors, you guys manage that. And so it's really an answer, I apologize, it's rooted in my own ignorance, because it's really based on my sort of skepticism about our ability to deliver on some of the promises we've made. Because I have a really hard time taking a view into the technology and assessing exactly what we need, because I just have a really hard time with that. I apologize for the sort of high-level answer.
Question?
Go right ahead.
So to follow up on that though, is the ACO in the center?
Yep.
Do you see that needing to be built out so that you have sort of budgeting information across all providers for Medicare, Medicaid, commercial, or is that ACO in your mind represent the ACO groups? Is each ACO group responsible for managing the information, or do you need it at a local or larger level?
I think for me, you're getting into, I think in a perfect state, I'd want to get that information from the ACO, right? But the interesting part of the ACO is you want to make it affordable, and one of the ways you make it affordable is by not duplicating what you already have. And so Medicaid's already a payer, right? We're our own little public insurance company. And so we didn't want ACO to go build a claims system, because we already have that. And so we sort of function in a way as the ACO's back office, and because we get our shadow claims, so we know what's going on, and we make payments on their behalf in a way in which they've specified. And so you're, again, at a really interesting point, because what we're really curious about is how their negotiations with Blue Cross and MVP land, right? Because they are also payers, and we're interested to see, like, what payer functions the ACO may or may not take, and what are retained by Blue Cross. And then for Medicare, Medicare is not going to let you specify exactly how you pay each individual provider. So there, the ACO really has to figure out to what extent it's going to become a payer. It'll function like a payer. We punted on that question because we thought the key in 2017 was let's get people on the bus and let's get the bus moving. But we have an earnest question for ACO, the one we have a relationship now, and any other we might have a relationship with over time, of how much do you look like a payer, and how much do you look like you're just optimizing what a payer does today? Other questions? I don't know how I'm doing time-wise. Good? Okay. You can be boring, but don't be long. Great. Another question?
On your quality measures,
Yep.
you said you've had 30 of them.
Yep.
What are you trying to look at, first of all? And are you doing anything innovative, such as patient-reported outcomes?
No. So, well, are we doing anything innovative? I would think of it as a pyramid. So let's talk about relationships and measures. So if we were doing a deeper dive on the ACO model, I would have had a slide that had a pyramid. Say there at the very top of the pyramid, there are measures that run between the federal government and the state of Vermont, which are those high-level access to primary care, chronic conditions, substance abuse measures, suicide prevention is one of the big ones we signed up for, which makes us nervous, makes our provider community nervous because you don't have a lot of control over that, but we wanted to find measures that made this real for Vermont. Then underneath that, there are quality measures between the state of Vermont and the ACO. So on our Medicaid program, we have about 12 measures, and the Green Mountain Care Board, our regulatory board, will have measures. Then there are measures that run between the ACO and the actual providers. And if you think of it, it really all works like a driver diagram rolling up into those big picture measures for the Vermonters. And so that's what we're trying to do quality-wise. The healthcare advocate recently asked whether we would do more patient-specific measures beyond just the normal surveys like HEDIS and et cetera. And including, right now there's some emerging stuff with cell phones. Can you text your experience back to people? And we said we'd be open to it, and I have to tell you, my staff came back and it was like the day after Christmas. They were like, wow, like, this could work. Because people want more beneficiary engagement in quality measures, but they don't know how the heck to do it. So you end up appearing to do something instead of actually doing something. And so we're open to new ways to do that and getting that into our contract in 2018 or 2019. But that's an ongoing dialogue for us. I don't know, I go to Dartmouth-Hitchcock. I had sort of a large health crisis right during the all-payer model. Ironically, the all-payer model nearly killed me. And I used to fill out the customer satisfaction thing on an iPad right then and there. And now doing this line of work, I fill out everything, right? My wife's like, you get so happy when the healthcare surveys come in, right? And I've even been called afterwards, be like, what was that too about, right? So we had a nice little chat about that. But that sort of instant feedback, that captures where I'm at, and I like that, and it's pretty easy. And so I'm trying to push our folks to be like, make this more real for people. Because right now, I mean, the only thing in my mind that's, that is nearly as impenetrable as the technology is the quality discussions. I get into a quality discussion, and it's an incredibly sophisticated discipline, and I'm really respectful of that. But much like that slide that says, hey, I can't support what I don't understand, I say that to our quality folks all the time. You need to make this real, because everybody's for quality, but you end up in a room and everybody's nodding, but nobody really understands. Yes?
So you've mentioned that you've got an agreement with one ACO.
Yes.
And there may be others in the future. Just thinking about the timeline to make this transition, it seems like you've got sort of a great playing field in that Vermont is small, very limited number of commercial payers, reasonable. What happens if you get more ACOs in the picture, and is there a scale at which the numbers don't work because presumably they would be sort of regionally oriented within Vermont and populations are different?
Well, you're making a good point. I mean, Vermont, its hospitals really don't compete, right? We basically have hospitals that are in catchment areas, right? So we had our own sort of thoughts like you of, hey, we're not totally sure, given hospital volume, you can have multiple successful ACOs. And that's why there has been a conversation over the last couple of years where there were 3 ACOs in Vermont. There's basically one that was hospital-driven, which is One Care of Vermont, which was partially owned by both Dartmouth-Hitchcock and the University of Vermont Medical Center. And then there was one Community Health Accountable Care, which is really driven by the FQHCs. But it's a lot of primary care lives there, and all the attribution methodologies are based on primary care. And so they really need each other. And then there was one, Health First, which was independent docs. And the independent doc ACO is really not in the game anymore. But there has been a merger between the FQHC ACO and the hospital ACO has been imminent for a long time. And so I tease them both, Vermont's a small state, being like, hey, isn't this the 3rd press release I've seen about you guys merging? Right, but it never actually happens, right? And you should never talk about religion in a public setting, but I was raised Catholic, so I get like it's imminent any day now, right? And that's sort of how I feel with our ACOs. So the merger is almost there. And so for me, though, we have your same questions about scale. As a guy who is like almost pathologically cheap, boy, I'd like some competition, right? Wouldn't it be nice to have a competition? Because the CMMI, CMS and the state of Vermont looks at this ACO agreement and say, to the extent there's only one ACO, federal deals are not usually so beholden to one provider. Like no ACO-based reform. And so we have a great relationship with One Care of Vermont, but it's a real risk to the whole thing that you're beholden to one provider. And that really makes us nervous. Now, right now, they've been great. Their CEO is probably, he really believes in this stuff, and if you hear him talk about it, you'll believe in it too. And so we couldn't ask for a much better partner. you know, now that we have a contract, I hear what you're saying, but you also need to perform, right? Which is a little different relationship than we've had in the past. But, you know, we've been interested in dealing with other ACOs, but you're asking a good question whether there's really sufficient scale to
Well,
make
in
it
both
go.
directions. I mean, you don't want one, but you probably don't want a dozen either.
Yeah, I don't understand how
They're
a
not
dozen would work.
be able
You-
to-
We were, it was interesting, we had a decision to make early on about whether this was gonna be a procurement for the Vermont Medicaid Next Generation ACO program, or whether we were just gonna set up an any willing provider relationship, right? We have a standard way in which we deal with ACOs, and anybody who wants to come to town can get paid. And we decided to go with a procurement. We got 2 bids, one from One Care Vermont, and one from CHAC, the FQHC ACO, in partnership with United Health. Or actually in partnership with Optum, rather. And that was really interesting for us, but they withdrew their RFP prior to consideration. Because we were just interested and curious of whether an outside player would want to come in. So, you know, we have a 1-year deal with One Care with 4 one-year extensions. It's our anticipated, you know, the governor will make a decision later on whether to extend it, but right now things are looking okay. And given the 6-year contract we have with the federal government on the all-payer model, it's our intention to get rolling unless we see results that we're not able to stomach. Other questions? Otherwise, thank you very much. I really appreciate
Mike, thank you. I love the humor you brought today. I think no one fell asleep, so that's great. We really appreciate it. I especially like the hallucination, you know, vision without resources is hallucination. So I think that's been up on Twitter thanks to Rob and Pat and me. So if you guys are on Twitter, follow New England Hymns on Twitter and kind of put out there what we're talking about today. So if you're not following New England Hymns on Twitter and you're a Twitter person, try to check us out. We're going to have our break in a few minutes. We ended a little early, so the break's going to go until 10:30. Make sure you go by the sponsor tables today, and some of them are raffling things off, so do that. If you can, put your name in the raffle. Also, the New England Hymns table is over here. We have a table if you're not a member of New England Hymns. We'd love to have you join us and learn more about it, and we are raffling some things off as well. So enjoy your break, and we're going to come back here at 10:30. Thank you.